I don't, this is the trouble of not being able to see an audience. So I don't know, you know, how many folks that are viewing today are new, or can I assume that most saw our introduction or you know, have an introduction to the program, or how much do we need to cover that today?
So just to give you some background, everybody here should have been at your initial lecture because you came to all of home-based primary care. So all of home-based primary care was there for your intro, and then these are the additional group who we've identified on top of that who need the additional training. They've also received the pre-work as well, although they were unable to open that intro PowerPoint slides as well.
Could, so I was able to record. For anyone who has video access, would you be willing to share video? I mean, we try to make this at least a little bit interactive. I don't know if that's possible, but that helps. Thank you.
Your audio went out for me for a second there.
My audio?
Yeah.
All right. Okay. No. You guys can see my screen, I assume, right?
Yes.
Okay. Anand, I can navigate as you go through the intro if you want right here.
Okay. So thank you all for joining us today. So my name is Anand Naik. I'm a geriatrician here at the Houston VA and at Baylor College of Medicine, and I lead our geriatrics section at Baylor. I've had the privilege of working with a number of geriatrics and geriatrics-oriented clinicians around the country, including my colleague who's joined us today on the phone, Lillian Dindau. Dr. Dindau can introduce herself in a minute, but she's a clinical psychologist and has worked with me and the rest of the team to really develop the program that we're showing you today. We have some collaborators around the country, so this is really a program that's taking root nationally, and we've been trying to embed it in the geriatrics clinic at the VA, and we're really excited by the fact that you all at home-based primary care are potentially interested in participating. We think that this is a program well suited for home-based primary care, as it's a program that was really developed to improve the way we deliver care for older adults with multiple chronic conditions, especially those in which we think that kind of the approach of single diseases and problem lists don't really work as effectively for this population. So we're proposing a somewhat different approach, though I don't think you'll find it that different from what you're probably accustomed to doing. In fact, most people in geriatrics, and I think especially in a program like home-based primary care, will say there's really nothing incredibly novel here. This is the way we do things anyway. And so I think that's great if that's the case. And so this is really just an approach to standardize that process that you're probably doing implicitly. But that this is not the way that our colleagues who take care of younger patients or in a more outpatient setting typically provide care. So I think it's sort of in that guise that we sort of began this presentation. What you're seeing in the slide here is a really 10,000-foot overview of what patient priorities care is. And it's really a set of 3 steps. The first step is to identify what the priorities are for a patient. The priorities are described as their outcome goals, what they want to get out of their healthcare, and what they're willing and not willing to do to be able to get to those outcomes. And today's presentation is going to be primarily a description of the process that we recommend for doing this structured identification of patient priorities as part of your routine care. Once you've identified priorities, we have a process that has been developed to write those priorities down in a note into a patient encounter that can be put into CPRS and then shared with the rest of the team. When that's done, then the whole team can see what the priorities are, and it allows us to do the next step, which is decide. And that's really to decide how much of the current care, the current treatment, medications, therapy, visits that the patient receives currently, how much of it is actually helping them to get to their priorities and how much of them is not really that helpful. It could be even harmful, and those are things that you might want to stop versus the things you might want to continue doing or doing more of because it would actually help them to get to their priorities. So that's sort of a process, and this might occur during your interdisciplinary team meetings. It's sort of a discussion of what the priorities are and whether or not our care is consistent with those priorities. And then the last step is where you actually go about changing care through conversations with the patients and the family members and other clinicians, and you really decide, are we, the care that we're providing, does it really align with, does it really help the patient attain their priorities? And what changes do we want to make, and how well, if we've made some changes, how well are those changes succeeding in getting to the priorities that matter? And the process is a bit cyclical. It goes roundabout in those steps. So if we think about, now this is just the identify piece, that first top of the triangle. And we think there really are 4 key steps and there's sort of an optional 5th step that are parts of that process. So again, we're talking about that first, identifying patient priorities. And we're breaking the identifying patient priorities down into distinct steps. And these are the steps. The first step is to identify the patient's values. This is what matters most to them. And we'll go into more depth in each of these steps. The second is transforming values, which are often kind of emotional, fuzzy things, into specific, concrete, meaningful health outcome goals. So this shows that you're actually living according to what matters. So first you identify what matters most. Now you want to show that you're doing what matters. And that's because you're able to attain these specific, meaningful, measurable goals. The third step then is once you identified goals, then you think about your health care and what you're willing and not willing to do to get to the goal. So sometimes patients have a goal, but all the care that they've got is quite burdensome to them, and they really don't want to continue doing all that care. Or there's some things that they think are actually helpful, and they would be willing to do more of it. Sometimes we realize that there are trade-offs, because, for example, if you say this is your outcome goal, but the care to get to your outcome is really burdensome, you really aren't getting to them despite the right treatment, that produces a trade-off that despite the fact that you're on the right treatment, you really find it so burdensome that it's not worth it, even if it helps you get closer to your goal. And so there needs to be a discussion of what are the trade-offs between treatment, between goals, etc. The fourth step is really empowering the patients to really talk to their clinicians further, and really getting patients to talk to their clinicians further, and really empower them to take these priorities and have them become part of the conversations they have with their other clinicians. And then the 5th step is sort of an optional step that, if there's a big change in your health or your life, you might talk about how you want to revisit this process. So it's a bit circular in a way. Okay, so, the whole point of this process is really that we are trying to get to identify what the health priorities are. And these health priorities are the outcome goals that patients really desire most and what they're willing and what not willing to do to achieve them. So it's sort of a summary of these steps. Next slide. I think it got stuck, Lillian. I'm not sure if she fell. Are you there, Lillian?
Sorry.
Oh, okay.
So I need a minute.
Okay.
Something just go.
Okay.
Go ahead and do this slide, and I'll be right back.
Okay. So so the first step is identifying your values. So this begins with a conversation of what matters most. And this is really where we describe a member of the healthcare team, which is a facilitator that is, my assumption you all in the audience today, you're the one who's going to come and begin to have these conversations with the patients and really walk through these 4 steps. And you know, what we're going to describe is how you do that and move through it. The first step is identifying values. So what matters most? So values are the people and the principles and the things that matter most to someone in their life. So again, they're kind of, you know, in a way emotional. They're the warm and fuzzy things. They're the things that really just matter most to you. And so they're often people and places that so the community you live in, the faith community you're a part of, the friends and family that are part of your life. The pets can be part of that too. So that's often some of what's valuable to you. You also might find what's valuable is certain meaningful activities or activities that are fun that you enjoy doing. So they could be hobbies, they could be your job, or it could be volunteer things that you do. It could be things that you really enjoy that occupies your time. And so that's sort of life enjoyment sort of values. And then a third set of values is really around functioning and being independent. So the things that, especially for older adults, right? So the things that they want to be able to do, that they can sort of show that they have some independence. And even if they can't do it completely by themselves, they want to maintain a degree of their dignity while they're still having people help them to do an activity. So sort of that balance sometimes of independence and help with dignity. So that's really the third set of values. So the first one was kind of social connections, spiritual connections. The second category of values is around life enjoyment, meaningful activities. The third set of values is around independence and functioning. And the fourth set of values is around, I'm just going to describe these. The fourth set of values is around managing health. So your health and your symptoms, your quality of life. And that's often a balance between quality and quantity of life. So when you're younger and you have fewer medical problems, you know, managing your health is really about just, you know, living as long as possible and staying out of the hospital or staying out of the doctor's office. So it's really around just longevity. As you get older and you have more chronic conditions, there's sort of a balance of managing health, managing symptoms, and then really the balance between quantity and quality of life. So that's what we see here. These are the 4 value families that we find to be really common in older adults with multiple chronic conditions. Again, there's connection, enjoying life, functioning, and managing health. They're really all 4 are important. There's not one that's always more important than the other for everybody. So we found that in our patients, you know, all 4 of them are valuable. They find something in each of these 4 domains of values that are important to them. It's important, and it's useful to identify something from each of these in a person's life. Next slide.
So, do you want me to take over again? Sorry about that.
Yes, please. No,
Sorry,
please,
everyone.
Please.
So we found it really valuable to actually systematically ask patients about each of the domains, because we found that if you explicitly ask about each of the domains, you often get information that might not have been reported spontaneously. And so this is kind of a little guide to just some basic questions you might ask. So under connecting, which relationships or connections are most important to you? Under enjoying life, what brings you the most enjoyment or pleasure, or even what used to give you enjoyment or pleasure? Functioning, when taking care of yourself, what is most important to you now? And managing health, what do you hope your health care can do for you? And there are more examples of these kinds of questions in the facilitator guide. So these sets of questions take, you know, you're starting to get a little bit more specific from someone saying, well, people are important to me, or family is important to me. Now you're starting to get a better sense of the context of this patient's life when you start to ask these questions. So this is a case study of Mrs. B. She's a 75-year-old woman with multiple chronic conditions, including atrial fibrillation, diabetes, hypertension, and arthritis. She often presents to her PCP, endocrinologist, pulmonologist, cardiologist with a range of symptoms, including fatigue, pain, dyspnea, and urinary frequency. And Dr. T, her PCP, is not really sure how to balance her competing conditions and symptoms. She's also uncertain if some of her treatments are helping Mrs. B and wonders if some of them may actually be causing more harm and burden than benefit. So just as a question for everyone on this group, does this patient feel like a classic example of someone you may see?
Yes.
So maybe in the chat box, you can just put a thumbs up or thumbs down. Okay. So for this particular, for Mrs. B, for example, this is what we came up with in terms of her personalized values. So she wants to be able to spend time with her family, watching her grandchildren in particular. She wants to be able to volunteer at the library. She told us that when we asked about enjoyment. And she wants to be able to lift items with her hands. And she actually talked about books at the library, and to be able to walk. So when we started asking about values, these are the things she told us were really important to her quality of life. So when you're asking patients about values, it's important to keep in mind that sometimes they're not very accustomed to being asked about values. When we started this work several years ago and we were doing qualitative interviews with patients, almost unanimously they told us like they had never been asked this question, or never been asked like what is most important to you in terms of improving or enhancing your quality of life, in terms of whether quality or quantity is most important. So just keep in mind that patients are often not accustomed to getting this question. And if they don't have answers right away, that's okay. One of the things we've said is that it's all right to ask the question and have the patient sit inside that question for a little bit, right? I mean, even if I ask some of you today, what are the things that are most important to you? You might want to like take some time to think about that, right? So just keep that in mind that this is a little bit of a paradigm shift for patients when they come to the hospital. They're used to being asked about all their symptoms and their list of symptoms and medications, and not so much about like their functioning and what's important to them. And they will often start to tell you all the things that are wrong with them, right? I mean, if you think about our interactions with patients, they'll give you a list of all the things that are wrong, the pain, the fatigue, the shakiness, the dry mouth, the whatever. And so this is a little bit of a shift in the conversation from, you're definitely interested in what's the matter, but you're more interested in what matters to the patient and how these things are actually interfering with what matters to the patient. So let's say the patient's main problem is pain. Then I might ask them, okay, pain is an issue. What would you be doing more of if you didn't have pain? If they tell you they're really tired and the fatigue is really bothering them, I would be interested in what is that getting in the way of? What would they be doing more of if they had more energy, for example? So other ways to put it is like, okay, well, what do you think you would be doing if you were having a good day?
Can I interject one thing, Lillian?
Yes.
I think what's a little bit different than kind of classic palliative care as it relates to this is, often classically as we think about palliative care, it's really to manage a symptom, manage a complaint, and try to reduce it. And this is a little bit different in that, a lot of our patients will have some symptoms, but the focus is not really symptom management or symptom control, but it's the focus on that outcome and all the things that Dr. Dindo just said. You know, what would you be doing if you had less fatigue or less pain? And what we're trying to get at here is for them to identify with that, what's most important to them there. And then we'll talk about how to make that into a concrete outcome as we move forward.
You know, so for how many psychologists are on the call? I'm curious. Okay. Angela, so it feels like kind of one way I think about this is, you know, the DSM, you know, how they ask first about like, you know, axis 1, axis 2, axis 3, axis 4. You're always focused on the disease and the symptoms. And this is kind of like turning it upside down, where you're more interested in axis 5 and the functioning and the quality of life and, you know, how that's impacting things. So it's a little bit of like turning things on their head. So, you know, the other thing, some tips about, you know, when you're trying to ask about values, and let me back up and say, I don't think that you need to actually use the term values, because that's often a loaded term. You know, often it has maybe religious connotations, or it's often a loaded term. I mean, the way we think about it is just simply like, what are the things that matter most on a very visceral gut level of a person? So it's not like, it's not, you know, this religious or loaded question. If you think that they're trying to tell you what you want to hear, just really clarify to them that there are no right or wrong answers. Values are values, and people have different priorities and different values, and there's no right or wrong about that. For some people, connection might be the priority, and for some people, it might be comfort. You know, there are no right or wrong answers here. So we have a lot of different examples of scripting, but like, for example, I want to make sure I understand what matters to you, not what others think you should care about. There are no right or wrong answers. The other thing about this is that often patients want to appease family members or caregivers, and that can often be a little bit, you know, it can be a challenge to really try to understand what it is the patient wants and not what they are doing simply to appease someone else. And I think it's worth saying that as well. If they're not able to articulate their values, just really review the domain systematically. And like I said earlier, it's okay to let them just take the questions home and think about it a little bit. So, yes, Leah? Leah, were you raising your hand?
I was going to put it in the chat box as well, but also just to say that we do have a workbook that's directed for patients and caregivers. And it's a printed material, and we'll make that available for you all in Building 110 at the end of the week.
So once you get a sense of, you know, what are, you know, the values of a patient, the next step is actually then translating it into really specific and meaningful goals. So one way I often think about this is like, you know, we can talk until the end of time about like what's important to us, but it means nothing if you don't put it into action, right? So I can talk about how important being a mother is, but if I'm not actually available to my child and spend quality time with my child, then it means nothing. I can talk about the importance of, you know, being a present and available colleague, but if I don't actually put that into action, it means nothing, right? So that's kind of how I think about it. Like, you know, you can talk about things, but really it's when it comes down to the action and what you do with it that it really starts to matter. So that's what this step is translating those things that matter most into specific and meaningful goals. And these are the activities that a patient wants to do, you know, what hopes to do on his or her own, or to do more of, and that are realistic and doable within the context of their own life. So you're going to review the patient's values, translate those patient values into specific and realistic health outcome goals. So again, these are activities that patients wants to keep doing in his or her life that are realistic and doable with their current life and health. So if a patient says their family is really important to them, that can mean so many different things for a particular patient. So Brandy, if I asked you what that would look like for you, what would you say?
Yeah, spending time with my family, that would be like my number one thing.
Okay, so it would be spending time. So now we're getting a little bit more specific. We're not quite as specific as we're going to get, but spending time with your family is one way. Angela, what would you say?
One thing that's important to me, are we in a specific category here, would be to maintain my physical health, to be able to be active with my spouse and my dogs, go on long walks, bike rides, that sort of thing.
Right, so it sounds like your physical health, right, is really important. And listening to you, it sounds like, you know, we're getting a little more specific here in terms of like you being with your family, biking and being outdoors a little bit, right? So, right, but I would start, so the next step is starting to like wonder if this is realistic for you, if it's doable for you within the context of your health and your life. So we have to really start to kind of drill down, is it realistic for the patient? Is what they want to do realistic and doable for them? Is it actionable for them? You know, biking 20 miles, that might have been something they really wanted to do, but it might not be realistic, right? Certainly, Angela, biking more than 3 miles would not be realistic for me. But, you know, so, you know, you're starting to get a little bit more specific. Brandy, I didn't get a sense like you want to spend time with your family. I didn't get a sense of for you what that looks like, right? So I would start to want to know, like, does that mean cooking together? Does that mean having dinner together? Does that mean going out regularly to the park together? Does it mean reading to your child, right? So this is how you go from something quite broad to something a little more specific. And we'll tell you why that's really important in a little bit. Well, right now I'll tell you why it's really important. So if you have a really specific goal, then this will serve as the barometer for whether the healthcare plan is actually helping the patient achieve that goal or not, right? So if a patient tells us, I really want to be able to walk to, you know, 1 mile a day in the morning, 3-4 times a week, but I'm not able to do that because I'm too dizzy in the morning from my medications, then we might adjust the medications, make sure they don't feel as, you know, hope that they're not as dizzy, hope they have more energy in the morning. The next time they come in to visit us, I'll say, were you able to take a walk that's 1 mile 3 times a week? Were you able to do that with the adjustment in the treatment plan? If not, then you start to work through what were the barriers. And if it worked, then great. You know, you did something in the treatment plan that helped them achieve something that improves their quality of life. Any questions? Anand, do you have anything to add?
No, I think that sounds great. I mean, we'll get into some examples here, but this is, you know, I think sometimes it's that transition from values to goals that trips. And the point here is really that goals are specific, actionable, and realistic. And we'll go into some specific examples.
I mean, a lot of you may have heard of things like SMART goals, you know, specific, measurable, realistic, time-bound. I think the thing that we're trying to do is, number one, make them specific and actionable, but they have to be meaningful, right? They can't be kind of out of context. Like a patient comes to you and you decide that you want them to exercise more. If that's not connected to their own, something that they value and something that they care about, they're probably not going to do it, actually. So sometimes you might say a patient is being non-adherent or not really, you know, taking your advice or not listening to what they need to do. And that's why it's really important to connect a goal to what is something they want to be doing. So that's the key part of linking a goal to what matters to them. It can't be something you just decide you want them to do because it's good for their health, because then they won't do it. So here's an example of a statement. What activities would you like to do that reflect what's important to you? So one of the things that we've already started saying is that it has to be quite specific. It's including exactly what the patient wants to be doing. And then this thing can change over time. It's not a static thing. It's the one activity that they really most want to do and that their healthcare can potentially help them achieve. And like I said earlier, it has to be realistic. You know, sometimes I'll give you an example of a patient we had actually at the VA geriatrics clinic. We had a patient who came in for months just saying he wanted to drive, and he was not drive. He wanted to go, yes, he wanted to drive, I'm sorry. He wanted to drive, and he had been saying that to Dr. Caddick for months. And he was in a wheelchair, actually. And we just kept asking, you know, like we just kept telling him, or the staff kept telling him that he can't drive. When he went through this facilitation process, what we understood is that actually he didn't just want to drive, he wanted to go fishing. And he wanted to drive in order to go fishing. And when we understood that, it was a whole different ball game. You know, we could actually provide services for him to actually go fishing in a wheelchair. So sometimes things might not be realistic, but if you understand what it is that's really important, you can help the patient find other ways to achieve something that they really want, right? Does this make sense? This is a really key point for geriatric, for anyone actually. You know, maybe someone wants to be a doctor, but their IQ and their intelligence is not high enough. You know, they don't have the money to do it. You could ask the patient, you know, you could ask the person, what is it about being a doctor that you really care about? Well, it might be because I want to help people. Okay, are there other ways to help people, right? So if you understand the value underlying, you know, the particular goal, you can help these patients find new ways to achieve their, or, you know, to honor their value. Okay, so I need you all to, well, not yet. So just in terms of tips, goals should always be linked to what matters most to the patient. If goals are unrealistic, try to identify an achievable goal that addresses the underlying value. And explore if there's an activity they can do more easily that still shows what matters to them. And this comes up a lot with our elderly patients who want to drive to see their grandkids, you know, who want to be able to do things that they can no longer do. So I'm going to give you all an example of how this plays out. So if a patient tells you they want to get their driver's license back to be able to go shopping, and that's unrealistic, and you try to understand what's the value underlying that particular goal, and they tell you it's really because they want to be self-sufficient, you know, it's really because they want to feel like they're still functional enough. Well, then maybe you come up with a different realistic goal of researching vision and hearing aids to better order things online, right? They'll still feel like they can purchase things and get things independently. So again, a patient might tell you, I just want to get my driver's license back so I can visit my friends. I just want to get my driver's license back. And now you understand that it has to do with connection. But this person has no way of driving again. Well, then you might work with the patient to figure out how they can take the bus to the senior center twice a week. The patient tells you they want to get their driver's license just because it's enjoyable and they want to be able to go for a drive. Then you know the value behind it is just enjoyment and recreation. Well, then an alternative might be to walk in the neighborhood. Brandy, did you have a question? Oh, I'm sorry, I thought you raised your hand. So does this make sense to everyone? Any questions so far? Can you all unmute for just a minute and like just tell me if this all makes sense so far or not? Any questions so far?
No, it just sounds like hammering in and narrowing down on the specifics of the goal to get a little more, obviously specific, or whether it's functioning or connection, whatever it is that their true value is.
Yes.
I think also letting them know that you understand what they're asking for when you kind of narrow it down, that they get that you get it.
What's your name?
Allison, Henry?
Allison, I think that that's a really important point, because one of the things we did hear from the patients was that they actually felt like we were listening to them and that we were trying to understand actually what they wanted. So you're right. Actually hammering it down is a way to validate what it is that they truly want, right? Versus you assuming if they say something that you know what they mean by that. So yes.
I also feel like we end up coming to this point after an admission and during our IDT meetings when we meet about the patient in a holistic manner across disciplines, that we end up coming to terms with, well, it's not that he necessarily wants to drive, but he wants to go fishing. That's what he meant. It doesn't happen overnight. It doesn't happen on admission, but it does happen with getting to know the patient innately for us.
So can you say your name and your specialty?
My name's Kelly. I'm a social worker.
Yeah, well, you're a social worker. So yes, that's kind of what you do, right? You try to get to these things. And so you're absolutely right. I think over time you might get to this point when you've known the patient for a while. What we're trying to do is streamline the process, make it more systematic, and make it like the first thing we address, rather than something we get, after, months and months of interacting with a patient. We're trying to streamline this and kind of make it the top thing that shows up on a note, actually. This is what the patient cares about most. Can we all get on the same page about this?
I think to underscore that a little bit, that was sort of my preamble to this, as I suspect many of you do this already. And, you're doing home-based primary care, and you're drawn from disciplines or professions that I think are just innately better at doing this than, let's say, a physician typically is. And you probably do all these things, like you said, over time and with getting to know the person. What we found with doing this process is that, our facilitators are usually able to, with a 20, 30-minute conversation meeting, able to get to fairly specific outcome goals and care preferences. We'll get into care preferences in a minute. At the conclusion of that encounter. I'm not saying it's always possible with every patient, and it does take a little bit of practice to get to that level, but that's what we're hoping out of this process, is that you've got pretty much a set of steps and processes you can work through, and you can get to this within a 20, 30-minute encounter. Your patient's a little more complicated, so maybe it takes a little bit longer. But we're hoping that we can get to a process that you're already pretty equipped at doing and knowing how to do, but giving you some tools to do it even a little bit more efficiently.
And I think, so this is Claire Campbell talking, I think it'll be helpful too if we know this right away, and if it is driving, say, the IDT, instead of going and having it being the last thing, if it's the first thing that we're talking about, it helps drive, maybe the medications and everything else. So I think it would be helpful certainly to have starting the conversation rather than getting to that eventually.
That's our hope, Claire. All right. I thank you for the thumbs up, Paul, something, I don't know. All right, moving on. So again, I need you all to unmute for this and put yourself on video if you want, because this is an exercise that I want to see how well we've been able to drill this down. Psychologists not allowed to answer. All right, so if someone says, I want to be healthier, is that specific?
No.
No.
We've got 2 no's and we've got 30 people
No.
on the call.
No. No.
No.
No.
No.
20 more to go.
No. No.
No.
Okay. You got it. It's not very specific. Is it realistic?
Yes.
Yes.
Yeah.
Yes.
Can someone expand on that?
By expanding, you mean what would we ask the patient to clarify what they
No,
mean by that?
why did you decide it was realistic?
Because health can be seen from many perspectives. So I think they feel healthier because they're getting better quality of life. That doesn't necessarily mean that they're getting better or that their cancer is gone or something like that.
Okay. What's your name?
Francisco, I'm Dr. Francisco Loaizaga. I'm one of the geriatricians. I'm sorry.
Awesome. Thank you. So anyone else? Why is it realistic? Anyone else have thoughts?
So this is Claire again. I think everybody can be a little bit healthier in some perspective. Even if you're, running a marathon, you might be able to eat a little bit better. But I think because it's so non-specific, it can be realistic for anybody. But I think to actually be realistic, we need to have a more specific goal.
Right. So that's, I think, the key here, that there's always something you can do to get a bit healthier. You can eat a little healthier, you can walk a little bit more, you can sleep maybe differently, right? There's always something someone can do, no matter how unhealthy they are or healthy they are, that can improve their health a little bit. All right, so what about this? Starting this week, I'll watch my grandchildren after school 2 to 3 times per week. Is that specific?
Yes.
Yes.
Yes. Yes.
Yes.
Yes.
Yes.
Yes.
Yes.
Yes.
All right.
Yes. Yes.
You all sound riveted. Yes.
Yes.
Okay. So is it realistic?
Depends.
It depends on the person, the situation.
All right. I think, so all I see is it says web. Did web say something? W-E-B-B-E?
Oh, maybe Sheila Weber.
Okay.
It depends on the person.
Nice.
It might be realistic for that person.
Yes.
Depends on the
So-
age of the kids.
And are they even in the same
Grandmother.
state? Are they even geographically close?
Yes. Yes. So ignore that I put a check here. Your answer is correct. It depends is the correct answer. I will start jogging a mile every day before breakfast. Is that specific?
Yes.
Yeah.
Yes.
Yes.
Keep going. Who else thinks it's specific?
Yes.
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 Here's the next question. Who is it realistic for on this group?
Not me.
I mean,
Yes.
yes.
Nope.
No.
Depends on the motivation factor.
Okay.
Donut.
All right. So you guys have got it. Like, it depends on the person. And for me, this would absolutely not be realistic any day, any month, any time. So that's something I could get healthier with. All right. So my next question is, are these values or are they goals? If someone says they want to go to a religious service every weekend, is that a value or a goal?
It's a goal.
That's a
I think
value.
it's a-
The value.
It depends on the person.
Oh.
It could be their goal, but it also could be their value based on their belief system.
Yeah, I think it's their goal also, but that it's based on the value of the community aspect.
Is that Allison?
That's Brandy.
I said
Brandy,
that it could be both, but somebody else had said that.
Brandy, is that you?
Yes.
Could you repeat that, please?
I think it's a goal, but that goal is based on their value of community or spiritual, whatever. I forgot what the categories are.
that
top left category.
Thing we did.
Yes.
So exactly, it's a goal because actually it's something you can check off the list, right? That's one way to distinguish between values and goals. A goal is something you can actually say, can I check this off the list? Yes. So if I tell you my value is being a really caring and present mother, is that something I can check off the list?
No.
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 That's not just a one-time instance.
Only if you identify something specific that you did that aligns with that. If you
Yeah,
can,
I agree with that. If there's a specific goal within that you set up, then yeah, it's measurable.
But that particular thing, me saying, I really want to be a patient and present mother, that comment, is that a goal or a value? Can you check that off the list?
It's
Value.
It's a value.
It's a value.
It's a value because that's something I have to get up and do every day, right? It's not like I can check off like, oops, I was a good mom today, done. You know, dodged a bullet for the rest of the year, right? I mean, and so going to a religious service each weekend is something you can check off the list. And you can say, you know, I did this. Now, what's the value behind it? Brandy, you're right. It could be spirituality. It could be that, you know, the connection with God or religion or spirituality. It could be to see people, you know, to see friends and stay connected to people. So it is actually, you know, a goal that you can check off the list. And the value often is spirituality, but it could be connection, staying connected to people.
Can I interject one thing there, Lillian? So I think, you know, for the folks who at first were saying value, you know, I think all the goals that we want you all to focus on are actually should be rooted in values, rooted in what's important, what matters most to someone. And one thing different than maybe some of the other goal setting that you've been introduced to before. Often those goals are very clinician focused, nurse or doctor focused often, and you know, are very medicalized in some way. So we're really moving away from those sorts of goals and moving to goals that are rooted in what the patient says, but more importantly, in what matters most to them. So I think that's, you know, also another difference between this work and maybe some of the other things you might have seen before.
All right. So the team here on the front, my front page, do you guys have a gallery view? I have Claire, Angela, I have Brandy, Allison. These are like, you know, the people that were in the front of the class. I love it. Being as independent as possible.
It's a value.
I would say that's a goal.
I'd say a value.
Both.
What
Is
about
one
the rest
closer?
of the team? Let's vote. So we've got value for
Value.
Value.
Value, because you can't check it off.
Yeah.
It's not measurable.
Value.
Brandy. What made you think it was a goal?
Oh, I said value.
Oh, you said.
Yeah.
It is very hard navigating the Zoom call.
I'm trying to keep
think that
myself
was
muted and
Eleanor.
unmuted.
Somebody
Angela, you said.
somebody
Angela,
just
you
called
said
me
goal?
out. That was Eleanor.
Sorry, Eleanor.
I said go. I'm Eleanor.
Eleanor, why did you say goal?
Because you can actually, if you can measure whether or not you're independent or not.
How so?
Because if I'm able to get up out of bed, make my breakfast, get dressed, and do everything that I need to do for myself, then that's my goal.
So that's
It's my
right. So if you
value.
think it that way, then it would be a goal. But it said here being as independent as possible. So it's not given any specific and measurable terms to it, right?
So
that's
I
what-
don't know if for you, it was the getting out of bed, it was the getting dressed, it was the making your own breakfast. So when we're dealing with, you know, elderly patients with multiple chronic conditions, being as independent as possible for them might look very different than it is for you. For you, being independent might actually mean getting up, making breakfast, getting dressed by yourself, so on and so forth. But for an elderly patient who's at a much, you know, they're much more further down the road in terms of their, you know, dependence, then for them, maybe just going to the bathroom by themselves is what makes them feel independent enough, right? So it's not, this is a value at this point because it's really non-specific.
So just to harp on this, because it's really an important point. So I think we have to be careful and not let something that's written like this, being as independent as possible, you know, that's very much in the eye of the beholder, between what the patient thinks is as possible, what the caregiver thinks is possible, you know, is independent as possible, what you as a clinician, what your colleague thinks. We're all going to sort of come up, we're all filling in the blanks. I think that's sort of what happens there. It's like, oh, I filled in the blanks. It's X, Y, and Z. But mechanically, for this process to work and for it to work as a team, working together as a team, the goal really needs to have as much specificity, realisticness, and meaningfulness to it. And we all have to be on the same page at the language of that specificity and meaningfulness and measurability. Only then is it actually useful for guiding treatment. That's the next, you know, this is a lot of steps in this process we're describing here. But the next step is how to link treatment so that you're showing that you're getting towards a goal attainment or priority attainment. The only way to know whether or not you're achieving that priority goal is if it has a degree of specificity, measurability to it, and that degree of specificity and measurability is clear, transparent to all of us involved, including the patient and the caregiver.
And just to piggyback off of that, if being as independent as possible is what they want, I would follow up and say, well, what does that look like for you? And so they can narrow it down to what it looks like to them. Because like you said, what they think is independent might not be anywhere near what I think is independent. And so by them having to elaborate and define what their idea of independence is beneficial.
Hey, this is Mary. The way that I'm understanding this in my mind is a goal is something that can be, as we said, measurable, checked off the list, whereas a value seems to be ongoing. That's just something that they really believe in. So that cannot be just checked off the list.
Right, absolutely. Mary, I think that's a very good way to summarize it, right? And again, if you want to kind of think about it yourselves in your own life, like think about, you know, the value of being a good parent or value of being a good partner or value of being a good friend. It's not something that you just do one day and it ends. It's something that requires ongoing attention, you know? So anything that requires, you know, anything that just can't be accomplished, you know, in one day or 1 week is going to be probably closer to a value. Contributing to my community. Is that a value or a goal?
Value.
A value.
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 All right. Getting a new job.
A goal.
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 That's a goal.
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 All right, crew, you nailed it. So what questions might you ask Mrs. B to help her verbalize a health outcome goal? So let me remind you of her. She's 75. She has AFib, CAD, depression, GERD, recurrent GI bleed, hypertension, arthritis. She has fatigue, pain, dyspnea, urinary frequency. Fatigue has multiple causes potentially and no clear etiology. She's not been adherent to her CPAP. She's had 2 admissions for heart failure in the past year. one for an upper gastrointestinal bleed. What questions might you ask to help her verbalize a health outcome goal? So she told us, you know, some of her values are her family and her grandchildren, right?
I think maybe asking or trying to get some idea of what is it that you enjoy doing with your family that matters, that you want to achieve, or that we can make happen for you.
Okay. Okay. We know she loves her grandchildren and wants to connect with them, right? But we don't really know what that looks like, right? So we know she wants to spend time caring for her grandchildren. She wants to volunteer in the community, especially in the library. I might say, like, what would you be doing specifically with your grandchildren? You know, what would you be doing specifically at the library? How often do you want to be able to see your grandchildren? How long do you want to be at the library? And it's important to also get a sense of, when you're working with patients, when was the last time they even did this? If it was years ago that they were able to go to the library, for example, then you might need baby steps before that, right? So also getting a sense of, you know, where they're at with this activity and how much progress they have made could be really useful. So getting more specific would look like this. I mean, we know now she wants to be around her grandchildren, right? But so the goal that she came up with was that she wanted to watch her grandchildren after school 2 to 3 times a week. And that she wanted to volunteer in the library, handling books 2 times weekly. So now we really have to understand how her health either helps this or hinders this, right? And so getting a sense of what about her health and healthcare is helping her or getting in her way to achieve these goals. And I'm going to let Anand take over now. Does that sound okay, Anand?
Yes.
Or did you want me to continue?
I'm getting all these very annoying pop-ups on my screen. I'm trying to get rid of. Okay. So we talked about, you know, really in this process of identifying priorities, there's, you know, 2 big chunks. The first is getting to a point where we've identified some outcome goals. And we've described this process that starts with values and then transforms a value, kind of a fuzzy emotional value, into a concrete, specific, measurable outcome goal. So I think that's an important thing. And then the next thing is identifying healthcare preferences. So this is what someone is willing and not willing to do to get to those outcome goals. What they find to be burdensome, what they find to be helpful, and really sometimes the balance between those 2. And that's really important to do, because even though we identify the outcome goal, if a patient or a caregiver are not really willing to do what it takes, or just what it takes is way too burdensome, it then becomes not worth getting to that goal. They're simply not going to do it, or they're simply going to avoid something that could be beneficial to them. So it's, you know, it's very important to understand what their preferences are. So I think I sort of said this. So this is really the two aspects of this: is identifying what's helpful and then identifying what's burdensome. So let's start with first discuss what's helpful. So, you know, as you're thinking about this and you're talking to the patient, you know, you've said, well, tell me, now you've told me what's important to you and what your outcome goals are. Now let's think about the best, you know, what do you like to do best about the way that you and your healthcare team are managing your condition? So what do you like best about the way you and your healthcare team are managing your condition? What do you find to be helpful? What do you find to be something that you don't mind doing or enjoy doing? So the patient might say that they're willing to take a diuretic even though it makes them urinate more often because they notice that it actually makes them feel better. So they're willing to do it. Makes them less short breath. Okay. So then you might come to what's burdensome. So, what's too difficult, uncomfortable, or time consuming. So are there some tasks that you're doing that you would actually like to stop or doing less of? So, I don't like going to the clinic every week. It's really just exhausting, annoying, and it takes me away from this coffee group that I really enjoy doing every time I have to go to the doctor's office. So you might also say, well, the doctor put me on a new medication and it makes me feel dizzy or tired, so I don't like taking it because it makes me feel bad. So invariably, when you're discussing what's helpful and you're discussing what's burdensome, there are trade-offs. There's a balance between benefits and harm. And sometimes the balance is in the way it is in this scale, which is a specific healthcare task is being balanced between a health goal. Sometimes it can actually be two different tasks. One task makes another task more difficult or easier. Sometimes it's between two different goals. So trade-offs can be complicated, but it's really, this is the real clinical decision-making that you all end up having to do. This is probably what you spend a lot of time in your IET talking about, is trade-offs and how to balance the different things that are part of treatment options. Okay, fine. So there's a worksheet here in the manuals we've given you. And let's, for example, use Mrs. B as the example. And so we think about all the things that she has to do for her care in terms of medications, in terms of self-care tasks or healthcare tasks you ask her to do at her home. It could be tests or treatments or procedures that she has to come in to clinic for, or someone comes to her home to perform, or actually having her to come do visits. All these things are the different types of care options, and that there are trade-offs in doing them. And I think you have the added complexity in home-based primary care of the caregiver's burdens and the caregiver's trade-offs. And to the extent that the caregiver, the patient is dependent on the caregiver and what the caregiver finds to be burdensome. So that's something I think that's a little bit even more complex in your population that you don't see as much in a somewhat more functional, somewhat younger population. It is the degree to which the caregivers' healthcare preferences are a big piece of this. So here's a script that you could use. It would be great if you could reach out to it would be great if you could reach your healthcare goals without having any treatment or any lifestyle changes that are hard or uncomfortable. Unfortunately, that's not always possible. Sometimes we have to make difficult choices about which treatments are worth the discomfort or burden, and these difficult choices are called trade-offs. So you might ask, what parts of your healthcare are you able to do and that help you to meet your goals? What part of your healthcare is too difficult or uncomfortable, or you would really just find very burdensome and you don't want to do anymore? So, that's sort of, let me pause there before we go to the one thing. Do you guys have questions about healthcare preferences, what they are, why it's important to ask them? I think it's important to document them. We recommend, we'll talk about at the end of this, documenting. I think it's probably clear why you need to document the outcome goals, especially the specific measurable outcome goals. But it's equally important to document the preferences, what people are willing and not willing to do, especially if they're really clear that they don't find something to be helpful, or they're not willing to do it, or they've had side effects when they've tried something like that before. I think documenting that is actually helpful as you continue to do more complicated treatment decision-making and treatment planning over time. So,
Dr. Nayak, I had a question. As we're looking to implement this, so step 1 and 2 seem like it really fits in that any any of us could do step 1 and 2. Probably the social worker, psychologist may be much better than the physicians, because that's how they're used to functioning. I think I'm excited that we're all going to start doing this. But step 3, is that when I know you've had social workers go through this training as well, does that need to be a primary care doctor, or can it also, just trying to get a sense of the burdensome and the trade-offs, can that be done by any of us?
So I'm going to guess that your social workers are quietly laughing, because they say the patients always tell us everything that they don't want to tell the doctors and nurses, that they don't like doing, find really annoying. And they won't admit it to the doctors or the nurse, but they'll tell the social worker that they don't like this. It's a pain in the butt. We trained, like you said, we trained a lot of different professionals in different settings. And I think everyone who's on this call is well equipped to do all the pieces that we're describing today. And sometimes it's actually even better that they're doing it as part of this. I find that sometimes patients open up after I've had that conversation about what matters most to you and what do you want to try to achieve, and really here to help you to achieve it. Now just tell me if this thing that I've been asking you to do has been a pain in the butt, you just haven't been telling me it's a pain. Then they tell you, then they're more honest, they tell you. So I think it's perfectly fine and appropriate for whoever's doing this conversation to do the whole piece of it. And I think they're actually even better after having had those initial conversations to have this.
That sounds good. Thank you.
Great question. So we want to close with sort of this last thing, which is the one thing that you kind of elicit from them. So, we've identified the outcome goals, we've identified healthcare preferences, and sometimes you might have identified more than one goal. Maybe you had a great conversation and you identified 2 goals, and you identified 2 or 3 things that they find helpful and burdensome. So then you're sort of ending this by saying, okay, now what's all the stuff we talked about, what is the one thing that you want us to know that you want to tackle first? Because sometimes this, a lot of your patients are complicated and messy, and there's so much to do, and you get lost. And then later on, they're going to have some symptom or some complaint, and they're going to forget about this one thing. But now you got the one thing down, so it's always important to remember that you've got this recorded. It's the thing the patient wants to focus most on first, and that they want to try to achieve in terms of their goals. So sometimes the one thing is addressing a symptom because it's getting in the way of a goal. Or sometimes it's a healthcare problem or a burdensome task. It's that one thing that's glaring they just want to address. This is similar to a chief complaint that we learn in clinical training. But it's sort of the one thing, and to be able to say the one thing that's getting in the way of my outcome goal, the one thing that really I don't enjoy doing at all, because it's such a burden. Right.
I think this came about because when we started training PCPs and geriatricians and other places like in Connecticut, one of the things that came up was, they have several things that they want to work on. They have several, problems, or they have several things that they want to achieve. Where do I start? And so that's where this comes from, is at the end of the conversation with the patient, we say, okay, you told me several things that are important to you and several things that you'd like to work on or have your healthcare help you with. Out of these things, what is the one thing you want to start working on right now? What is the one thing that's most important for you to work on right now? And it just gives the healthcare provider a place to start when there's, more than one thing. So, sorry, go ahead, Anand. I didn't mean to interrupt you. Well, I kind of did mean it, but
No, that's great. Okay, so this is really summarizing it. The one thing the patient wants to focus on is this, so that he or she can do more of that. So the one thing the patient wants to focus on is their back pain, so that they're able to spend more time with their grandkids, playing with their grandkids. So it's, again, often that one thing is either a symptom or a health problem or a burden related to their health care that's getting in the way of getting to that goal. And this is sort of, as things happen, there's always a complaint. You got called to see the patient because there's a symptom or something that's arisen. And so maybe that takes over as the one thing, but sometimes it's not. There's a lot of little nagging things that you get distracted by, that you sort of want to remember that this is the one thing. If you can actually tackle this one thing, you make a lot of headway in terms of making progress in patient's goals. So at the end of this is sort of a template, and we've created it into a CPRS note that's sort of on the right, which is, identifying, quickly what matters most and values. These are just quick statements about what they find to be valuable, kind of the warm and fuzzy. But you want to transform that into some specific, measurable, meaningful goals. And so, these are, again, things you can check off, watch the grandkids after school 2 to 3 times a week. You could even, that one could even get even some more detail. So can the next one. Volunteer in the library. No, this is pretty specific. Volunteer in the library, handling books 2 times a week. So she wants to be able to volunteer in the library twice a week, and she wants to be able to do that in such a way that she can actually manipulate books. And as you think about this, I think this is very accessible. But let me think about that second one. As I start to think about this patient, you've already gotten me thinking about her medically as well. So how well is she able to get up and get around? How short of breath does she get? Does she have arthritis? Does she have enough strength in her arms to lift the book? You already sort of got me thinking about the different conditions she has, the different things that might be getting in the way. But now I'm thinking about her holistically. I'm not thinking about her from single diseases alone. I'm thinking about putting it all together in terms of those outcome goals. So how will I know that later on, how will I know that I'm successful in getting to those goals? It won't be because, I treated her osteoarthritis. It'll be because she could actually hold books to volunteer twice a week. So that's the importance of making meaningful, measurable outcome goals. And then you want to document preferences, what people are willing and not willing to do. And of course, this is really important as you're going to have to think about treatment planning. It's important to know what the patient and caregiver find helpful, what's the things they've tried that do work or they would be willing to do more of, and then what's burdensome, what they don't want to do, what they find very burdensome. And CPAP has come up because often people have described that as burdensome, and so that also creates a conversation because often they'll describe an outcome goal that's really important. So let's say it's being able to watch your grandkids for 2 to 3 hours. We ask her, why aren't you able to do that? Well, I'm just really fatigued, especially in the morning. I'm really fatigued and I can't. And then you're like, well, you've got sleep apnea. You're thinking in your head, you have sleep apnea, and the CPAP might actually be something to do it. But no one's probably said before, I know the CPAP is a little bit burdensome, but I actually think if you did it let's try it for a week and see if it helps you to get to this goal, if you're able to spend more time with your grandkids without getting fatigued or short breath. And so give it, sort of give it a try. And so even though it's on her list as burdensome, I've taken that discussion and I've refined it in a way that she's going to try it out because it might actually help her to get to that outcome goal. But it's important that whoever did the facilitation documented CPAP was burdensome, because then you realize, well, you know what, she probably isn't doing it because it's so burdensome, and that's why she's still so fatigued and can't do her goals. So it's important to think about that. Either we have to put that aside and find something else, or we have a real frank conversation about trade-offs and seeing what she is willing and not willing to do in terms of the trade-offs of the CPAP and her outcome goals. And then you think about this with the medications as well, and their current medications, what's helpful, what's burdensome. Medications are often a big signature piece, and so that's why we sort of separated out here. And then thinking about that one thing, what's the most bothersome symptom that they have, and how is that incorporated into the one thing? So this is the way we've done this particular template ourselves with a number of different teams. I think that it doesn't exactly have to be there. It has to be exactly like this. In fact, we've tweaked this several times. It didn't look like this the first time we developed it. So I might say to the team here that, I want this to work within your workflow and make sense for you all. If you need to reorganize it a little bit, I think that that's okay, as long as you're documenting the key components, which is the values, the outcome goals, and the care preferences. As long as you have those in there, it doesn't exactly matter to me how you arrange it all, And you might have other things that are part of your IDT or your notes. But this is really the key thing that we want to get out of that facilitation. The whole thing we've been talking about so far, this is what we want to get out of your facilitation visit, and we want you to be able to document. You want to add anything to that, Lillian?
No.
Okay. Okay, so the summary of the priorities, that we described that, your outcomes, your healthcare preferences, discussions of trade-offs, and it's really important to identify them and document them into the record.
So the other thing is that sometimes it's nice to, sit down with the patient and have them write it down as well, because sometimes they'll take, a sheet of paper to their healthcare provider and talk to them about it. So we have found that could be valuable. So in addition to, you documenting it in the note, in the electronic medical record, there is a summary in the patient manual, and it doesn't have to be from the patient manual. You could just take out a paper and pencil and just say, okay, here's, a little note card with what, the summary of what we just talked about. Feel free to share this with, your healthcare provider the next time you go. It does serve as a nice starting place for them to discuss, their own priorities with their healthcare prower. So
now, in a primary care setting, they might not be able to travel to provider. But where I think it's also valuable to write this down is to really get some specific documentation and discussion between the patient, the caregiver, other family members, especially if you're having to document the family members and care preferences as well. I think that's important then to have a written document that the patient and the caregivers hold, because it needs to be clear to other caregivers and the patient, what is burdensome, what's not burdensome, what are some active trade-offs that you discussed during this visit.
the other thing that's interesting about this is that, sometimes people are pretty hesitant to discuss end-of-life things when they're somewhat still healthy, but it can be quite valuable for patients to be able to articulate these things to their caregiver or to their family members, so that it's not just assumed that the family or the caregiver know what the patient might want as they deteriorate. So right now, although they might have chronic medical conditions, they're still able to articulate what it is that they would want. So that can be valuable as a discussion point with their family members and caregivers.
So, one thing that we've said, a number of us have said, is that this is somewhat akin. So this is similar to palliative care. It's somewhat akin, but this is not advanced care planning. It's current care planning. So this is sort of what you want to get out of your care right now. But I think as like what Lillian's saying, as things progress over time, this can go from advanced care planning from current care planning to more traditional advanced care planning as their condition advances.
So I have a question. We have a lot of our providers, the social workers, psychologists are not actively going and seeing patients. I know in the geriatric clinic, you guys have done some stuff over the phone. Are you able to share or at least discuss some of the different conversations that you guys have had over the phone, or are you able to do it? And have there had barriers?
I had there's a patient that I was consulted on. It was a co-management. So this is in geriatrics clinic, and it's a patient that we're not the primary for. The patient came from a PPP. I think the original consult was actually for polypharmacy and addressing some drug-drug interaction. But what became clear in the first, I started doing PPC essentially with him. So it was actually mostly by phone. I don't even think I had good video connection for most of my calls with him. I've never seen this patient in person in clinic. I think I've had 3 phone calls now, or 2 phone calls and 1 video visit or something like that. And a lot of the conversations with his wife, not just him. But it became very clear in the first meeting that we were talking about values and goals, that it wasn't just polypharmacy, but that he had fairly advanced lung problems. And it's not just one, he has both obstructive and restrictive lung disease. So that's part of the problem, is he doesn't have one traditional lung disease. So his COPD is moderate, it's not advanced. So between his COPD and his restrictive disease and his asbestosis disease, all those combined actually have caused them to have fairly advanced pulmonary disease, but it's not one disease, right? It's just a combination of all three. But it's hard to get the pulmonologist to say, oh, he has one terminal diagnosis, because he doesn't have one terminal diagnosis. Just everything combined has created dysfunctional status of what he's really not really able to do that much, not able to get around very much. A lot of his symptom management is just day-to-day. So there's the first conversation of, what's meaningful to you? What's a good day? What are you able to do? Let's try to identify a set of outcomes that we want to try to get to in terms of your treatment. And so that was sort of the first conversations. And then I think the second conversation was, do you guys realize how serious the illness is? And so I ended up doing an LST note, advanced care planning, after I had that first visit where I really identified the priorities and all that. And then I had a third visit where he again presented to the PCP with some acute symptoms. But again, I think this looks like a home-based primary care patient. We're never going to really get you much better. I'm trying to manage your symptoms to improve your function and meaningful outcomes for you as much as possible. So now I've actually done a palliative care consult for him to help them help manage his aggressive pulmonary symptoms so that he can achieve the outcome goals that I've conversation with before. So this is a fairly personal, difficult conversation I've had with him and his wife over three or four, mostly phone visits, with a PCP means well, but I think is struggling with the traditional sort of disease-based approach to care and is having trouble identifying how to approach this patient because it's all through the lens of disease-based care, and wasn't comfortable consulting palliative care because they didn't see this as a single end-of-life diagnosis. But I didn't consult palliative care for that. I consulted palliative care to help me with some pulmonary symptoms that I think they're best equipped to manage, right? So, I hope I'm getting to your point is not that I was a good clinician in this example, but that this is a pretty complicated case that you would typically not imagine you could do by the phone. I actually think I could not have done this over the phone through a non-PPC approach. If this was a typical medical visit, I don't think I would have gotten where I got with the patient. I think it's only because I took very much a PPC approach.
I have a question. This is Eleanor. In the chat box, when you're talking about the Alzheimer's Association and recognizing the importance of documenting what matters before advanced disease sets in our program, sometimes they're already advanced. So I'm trying to make sure I understand that with this, focusing on the goals and values of the patient, why would it apply if the patient is not able to effectively participate in the whole process? Like basically we're going to be making the goals and values based off the caregiver. So would this apply?
Sure, it does. And so it gets a little trickier. I and some colleagues of ours have done some work with patients with fairly advanced dementia. And, two ways that you can think about approaching this. The first is you do want to engage the patient as much as possible, but let's say you can't, or you can only minimally. I think it's an important conversation to have with the caregiver to really identify what are the values that the patient had. And this is sometimes where the patient's values, the caregiver's values, it's not clear where one begins and the other ends sometimes. And so admittedly, sometimes you're co-constructing values and goals that's somewhat shared, but you don't want to make this strictly about the caregiver. You do want to find, patient outcome goals. What is the patient would have found valuable or had found valuable previously in their life that they would still find valuable? And how can we craft that into what would still be a meaningful day for them? What would be a joyful day for them, even if they couldn't articulate it? Have the caregiver try to articulate it as much as possible. And over time, and it's certainly as things get even more and more advanced, you can't completely separate out what the caregiver's goals are. To some extent, maybe it's a shared goal of the caregiver and the patient, having the patient be able to do something from a daily functioning perspective. That's important for the patient functioning, but it could also be important for the caregiver. It makes the caregiver's life a little bit easier. if the patient's able to do that functioning. But I would tell you to be okay with even a situation where you identify strictly a caregiver goal, because it's a goal around caregiving, and it's an important caregiving goal that helps the patient overall, even if the focus is on the caregiver, because it helps the caregiver take better care of the patient. And so I suspect that things get worse, that is part of what you're doing, is that you're going from a situation where you're constructing, 90% the patient's values and goals, to then increasingly a more and more shared situation of a shared value and goal between the patient and caregiver. And then maybe toward the end of life, it's even one that's a little bit more focused around the caregiving of the patient. So I think, honestly, as things advance, this becomes even more important, because what's the alternative? Like, why is a disease-based approach relevant to an advanced care patient, advanced disease patient? Right? Who cares if this guideline in the disease is better? What you really care about is that the patient and the caregiver, their lives are better. That's what matters.
It almost seems to me that this approach might sort of serve as an avenue to address veterans' wants, needs, preferences, even if they may not have full capacity for decision making, sort of in collaboration with a caregiver. I'm thinking of some people that we've worked with where maybe they don't really have capacity to make a medical decision, but there is an intervention that the family wants, that the veteran can clearly and consistently express is very burdensome for them. And it seems like this might be an avenue for discussions around that, where we don't have to limit it in this really maybe false sort of black and white way, whether or not they're decisional, where it may open a door. I don't know what your thoughts are on that, but open a door for a different kind of conversation than maybe we don't always have with the caregiver about what sort of the veteran is clearly and consistently expressing, even if they're not capable of understanding all of it.
So we've had a lot of conversations about that over the years that relates to this. And that's another reason why we start with values. So, no matter what your capacity is, you haven't lost your ability that's the most human thing that we have. So you haven't lost your ability to have values. And even if you can't articulate them anymore in your life, you lived a life that has values in it. And that your caregivers know, your family caregivers know what those values are. A caregiver who really cares about the person they're caring for will try to honor those values as much as possible. And that is the basis for the conversation. So even when medical decision-making gets difficult, and where goal setting sometimes gets difficult, it should still be not easy, but easier to start from the values. And that's really why we start from this place, with values, and let that guide what you're doing, and you find a meaningful goal that helps the patient honor their life according to those values. They don't, you're right, they don't necessarily have to, as long as they can provide assent, they don't necessarily have to provide consent, as long as the caregiver provides the consent if they're the legal guardian, right? But I think, knowing what's burdensome to the patient, what's burdensome to the caregiver is another way of showing values and respect to the patient and what you're doing. And sometimes, I feel like sometimes when we're doing a lot of really intensive care, we're in shaky ground when it comes to patients like this. But I never feel like we're in shaky ground when we start from the values and the goals. I always feel like very, like in the example I was giving you, the PCP was uncomfortable consulting palliative care. I felt very comfortable consulting palliative care because I knew exactly where the patient and the family members' values and goals were and where they were in their lives. I felt nothing wrong about trying to do that, even though we didn't have exactly the pulmonologist diagnosis, their feelings of the diagnosis.
Hi, this is Swan Haybark. I'm one of the psychologists here at PPC, and I have kind of a comment and question that may just answer itself as I'm talking here. But I'm wondering if the facilitators.
I can't hear you. Can others hear
Can
her?
you guys hear me? Can anybody hear me?
It's very,
Can you
very,
hear me?
I can hear that you're talking, but it's really low.
You sound very distant, Swan.
Can you guys hear me better now?
Yeah, that's better.
Okay. So what I was saying is, I'm a psychologist here in the program, and this might be just more of a comment / question that might just answer itself as I'm talking. But some of the folks here in the training are not medical providers. So I'm just thinking about being a facilitator for this and not being trained in medicine. And I'm wondering if those of us who are going to be eliciting the goals or facilitating the goals, if we should go into it knowing about certain medications or treatments that are kind of medications or treatments that has to be kept. I guess I'm just thinking more about the parts on the worksheet where the patient might be talking about their 3 unhelpful or difficult medical activities or medications, and I'm not sure what side effects certain medications might have on other ones, or if they remove that, that's going to impact different organ systems, and this might be something once the goals are put on that worksheet. Again, it then gets disseminated to the team, and it will then be discussed among the team and the clinicians and be adjusted that way. I think, wondering what your thoughts were.
Well, I want to alleviate your concern on that. So I think that you don't need a lot of medical knowledge, at least not, you don't need to be an NP or a PA or a physician or even a pharmacist to do the facilitation. We've had a lot of other psychologists, I think psychologists and social workers are probably the best profession, to be quite honest, to do the facilitation piece. I think your training is just very well suited towards it. And we really just want you to have the discussion of values, outcome goals, and just ask about care preferences and what they find burdensome. It doesn't matter if it's exactly right in terms of the adverse events. That's not the point of the facilitation piece. That can come out later on as you're doing the next steps where you're aligning care to treatment. And so that's really more where that comes into play. And again, I think that with the question that came up earlier, sometimes patients are not willing to disclose that they find something really burdensome to their doctor or their nurse, but they will disclose to the facilitators we found. So I want to say don't feel intimidated by that at all. And in fact, I think that the non-medicalized professions are probably the ones that are better suited sometimes to be facilitators.
And I think just to piggyback, I guess, on Swan's question, just because they're in there and you guys are having the discussion, you're actually finding out what the burdensome care is. I think then as a group, we could potentially go back in the IDT and discuss, well, is this a necessary burden? How can we address it with the patient? Or, and having the PCPs have some more information to be able to have the better conversation with the veteran. So even though it might be a burdensome care on the document, I think it's useful for everybody's information, not necessarily that you need to be making the changes during the facilitation.
Yeah. Is it sort of similar with the idea, with the idea of sort of realistic goals? So if we were doing this with patients who are new admission stage 3 PC, we don't know them very well. Being non-medical, I can look at the chart and I can see some things, and I can be with the person and see some things about what may be realistic. And I can use these great questions like, what's a good day for you, to get an idea of how they're functioning now and what may be realistic. And as a psychologist, I certainly feel comfortable starting with a goal. And as we continue to work together, modifying that goal as I get more information, and as the person gets more information, has more moments of sort of being able to reflect and insight, that sort of thing. I'm just wondering if there are any thoughts about a non-medical person sort of working on those goals and that aspect of maybe we're not sure how realistic it is, and what that then translates into with the physician and treatment planning with all the other disciplines.
So I think, I just want to say that I've definitely encountered the same anxieties as Angela and Schwan, is it? Schwan, sorry. I've definitely encountered those same, anxieties. I'm a psychologist, and I'm surrounded by all this, the healthcare preferences. I mean, I don't even know how to say half the medical illnesses, I don't even know how to pronounce them. I think that that doesn't actually turn out to be much of an issue because you're still getting the patient's perspective. You're documenting what they want, the way they see things. And actually, it's the PCP or the geriatrician's job to then align, the care with the goal. And if it's unrealistic, then that's something that their healthcare provider can tell them, their PCP or geriatrician. They can tell them, that's a great, I appreciate that you want that goal, but it's not realistic. But if they then have a documentation of the value and they know what's behind that value, then at least they have something to work with, right? And so I wouldn't worry as much about getting like this really super realistic and, you're sure that it's going to work kind of goal, as much as like trying to understand what's the value behind that goal so that the physician can then know, what would potentially be. But I guess I just wanted to validate that I know what you're asking, because I felt exactly the same way. And I still feel that way sometimes. And that's why Anand does section 3, the healthcare, the burden, helpful care, burdensome care, because sometimes I feel like it's above my head. But patients are able to articulate, like, I don't know which medication is doing this, but I feel dizzy and I don't like the dizziness. You can document that. That's enough. You can, I have to go to the bathroom all the time. I don't know which medication. This medication is making me go to the bathroom. I don't like waking up 6 times a night. We can document that. Sorry, Anand, I just wanted to validate psychology.
Thank you.
I have a question.
Just one comment on just the second half of what you're saying. So honestly, at the end of the first facilitation, especially after a new patient, none of us know what's really realistic, or even if it's specific enough. So you want to try to get to be as specific and as realistic as possible, but the honest truth is it rarely is specific and realistic enough. And you sort of have to, I say you have to try on the goals for size. You have to try the goals on in your life. And so over time you realize, oh, that wasn't that realistic. And that's the other reason to start, Lillian said this, that's the other reason to start with values. Because sometimes you think you have a goal, it didn't really work out right. That's not really the right goal. Or I tried it on, it was completely unrealistic. I don't really like this goal. I want to pick something else. But you want to start from what's what's important to you, what's valuable. But that doesn't change. That's still the value. So you might actually drastically tweak the goal to make it more realistic and specific over time. And you'll realize that, over time. So you won't ever get to really specific measurable goals the first time you do facilitation.
Okay, this Eleanor, for the ones that's done this before, can you give an example, like if you have the caregiver and the veteran, their values and goals are completely different? You've tried to narrow it down to where it has some type of semblance of agreement, but there's none. Can you give an example of how you overcame that in order to make this work?
So that's a trade-off, right? Immediately, the fact that there is so I would say you've reached a success, a mild success, if you've clarified that this is the patient's value and this is what their goal would be based on that value. This is what the caregiver's value is, and this is what the caregiver's goal relates to that value is. And these things are not congruent. These things are causing conflict. If you get to that step, that's a minor victory. Like, I think a lot of what we tackle in healthcare is because there's an implicit problem or there's an unstated problem between caregivers and patients, and no one's really clear what it is and why it's occurring. So this process just helps you to clarify that conflict. That is an immediate success. It doesn't sound like a success, but it is. Because only then can you start to have real conversations about, well, this is why neither one of you are really happy, because you really have very different approaches, and we have to try to reconcile this and try to find some way to get to shared goals. And sometimes the way to get to shared goals is to identify values that are important between the two of them. And so sometimes elicit the goals conflict because, I know I'm not being specific enough here. But sometimes, you want to, I don't know, I can't think of an example right at the top of my head right now. I don't know if someone has an example where they've had a patient and a caregiver who disagree because they have different goals.
I have an example. I'm working with a veteran who I have yet to been able to sit down with the veteran and the caregiver, but I'm working with a veteran who has a history of stroke with cognitive impairment that has improved some over time since the event, and also a significant cardiac history. And his sister doesn't want him driving, and she is his caregiver, and he wants to drive again. And we've certainly identified that the value behind that is independence and autonomy. There are certain tasks that are about connecting to others activities he would like to do, but he'd like the autonomy of getting himself there. We've sort of problem solved through possibly taking a bus, which he is open to. His sister feels that would be dangerous for him as well. And so her primary goal is he had an event when he was driving in the past presented as a significant risk. So one of the things we're working on as a team right now is to get clarification whether or not there's any medical reason for him not to be driving, try to get a driver's test. But I think even if he's passed on that, since she's the one providing care and he's living in our home, it's going to continue to be a point of conflict.
So I think you're raising two things. So one way you can use this approach to help you get to it is if you clarify what the two different goals are, and you can try to find a way to reconcile them in some ways. It sounds like in your example, Angela, you guys have tried to do that. You've used the underlying values to identify new goals that they might agree on. And so that's the right approach. You're using very much a PPC approach in the example you gave. So you try to recraft the conflicting goals to create a new goal that might not conflict because the underlying value is still there, right? And you tried that. And I would say actually a lot of times that works. The approach you use works. Sometimes it doesn't work. In an example you described, it doesn't work. So you're going to be at an impasse there between the patient and the caregiver. And so where it really comes down to is, is he really not safe to drive in this case? And if he can prove himself not to be unsafe, and he has autonomy, you might have to allow him to do it, but she's really against it. So there's not I think you try to work through this. Sounds like you've been at it for a long time. You try to work through it a lot. You've done all the steps, I would say. You get to a point here, and at least it's clear of where the impasse is. And then sometimes you have to agree to live with that impasse. You can't completely resolve it. It sounds like you have one or two more steps left in this example to try. And maybe if he can prove himself through the driver's test and some other things, and he just drives, let's say, just around the block. It's just the joy of driving, right? So maybe she should be content with that. And after he does that half a dozen times, she might be okay with it then, right? And so I think that's the process. I mean, you guys work with a set of patients and a set of challenges that are particularly difficult. There's no magic bullet. But I think this process is probably going to give you more tools than the typical sort of disease-based approach does. I think that's what I would say to the original question.
Do we want to go on with the PowerPoint?
Oh, there's more. Said a lot of this, which is, I think what we often try to tell the patients is then try to be proactive and talk to because often this is in an outpatient setting. So so you're the facilitator, you had this conversation with the patient. Now you want the patient to be an advocate for their own values and goals with the PCP that you work with, but then also the specialist in the other PCPs and things like that. So we really encourage patients to ask questions to all their clinicians, tell them to be honest, don't hide their burdens, don't hide their problems, share them, voice your values, voice your goals, be your own for those sorts of things. And then we tell the clinicians that sometimes the patients don't talk about this because they're embarrassed, because they're deferring to the doctor or the nurse, to the psychologist, or the person of authority. because they have challenges with health literacy or capacity, and because there's not enough time in it. So if you tell the clinicians these are the barriers, then it maybe gives them some space for the patient to kind of get around those barriers. And the last thing is, I think COVID is a big example of this. It's like, okay, I've had some conversations with patients and we've identified goals and values, and then something like COVID happens and they can't do half of their goals because they can't even leave their house, or heaven forbid they actually got sick and it really changed their health in a dramatic way. Well, that might force us to go back to the beginning and revisit our values and goals, or reorder our goals based upon how our values and our life has changed. And so, you guys, because you have such longitudinal experiences with your patients, I suspect this happens frequently, where you're going to have to revisit where you are with the patient and sort of go back in the steps a little bit and redo the care preferences and outcome goals to some extent. All right. I think we've said a lot of this. So I think there's some scripting both in the handbook to give tips for patients and for the clinicians about how to encourage patients to talk. And again, this might be most relevant in the context of caregivers and patients, helping the patient and caregiver talk to each other about their values and goals, being really clear about them, and being, you could probably put some of this in the context there. We've done this section in the context of the patient advocating for themselves with other clinicians, but maybe it's also the patient advocating for themselves with caregivers, and caregivers being mindful of that. This is just a summary of the steps, and I think we talked about these a lot, so I don't want to hold you guys long.
I think so there are lots of resources as well. There are these slides that we just went through. There's also an online course that you can get credit for through the American College of Physicians on how to identify priorities. We have the conversation guides, which I think Leah is going to provide you with. And then there's an annotated health priorities template that just kind of really simplifies some basic questions you can ask for each domain. I think this has gone, no, it hasn't gone live. We've also developed a self-directed health priorities identification website that we're hoping patients can go to the website and go through the process themselves. Actually, that should be going live hopefully in the next few months, but we basically kind of have an animated version of what we just did to help patients walk through their own priorities. So
well, go ahead.
Go ahead, Anna.
No, you finish. I'm sorry.
No, so that's the facilitation part. And then there's the alignment piece, when the clinician aligns healthcare with the patient priorities. And there are another set of trainings for that. The clinician training slides, also PPC courses through the American College of Physicians. So there's the facilitation piece and there's also the alignment piece. And then there are decisional guides, online resources of strategies, scripts, and challenges. Go ahead, Anand.
More tools. Yeah.
I think this is it.
So, I think I was going to say is, I think it was because the fact that, something that you guys do already to a large extent in your own practices as part of home-based primary care. You guys are very accustomed to doing these sorts of conversations, and you guys have a lot of these skills. So if nothing else, this just provides a little bit of structure. I also suspect, given these conversations we've been having today, you also have probably some of the more difficult cases that we're going to encounter. And it's a little bit tough to talk about them esoterically but maybe we can talk about them as we go through this, through some of your specific examples. And so when we've done this training before, we sometimes have follow-up sessions where we do really what's kind of case by case audit and feedback. So you can bring one of your cases that you've done the facilitation with, and maybe you filled out that EHR template. At least you've identified the values, outcome goals, and care preferences, and you can relate kind of the story of the encounter and the challenges that you might have faced, especially some of these challenges between patients and caregivers, or just more complicated patients. It'd be great to then talk through those examples. I'd enjoy, you guys can probably give a master class on how to do this to a large extent with the kind of complex cases that you have. So I think that would be interesting to do with you all, and I think would be valuable.
Dr. Nayak, we really appreciate you, you guys both coming and doing this presentation. I think we're working towards trying to implement this in home-based primary care, and we have a kind of a champions group from all the disciplines, with the exception of nursing, but hopefully we'll get some of those. I was just going to go into some more of the practical details, because I think that we're hoping to meet with you again probably sometime next month and doing the next step. So after we've started to identify these problems, what the next steps are and how we can integrate it within the IDT. So just from a practical standpoint, we're working with Leah to try to get the CPRS template and trying to do health factors as well, so we can try to track it. And we're trying to get the user guides. I know, Leah, thanks for sending it out and for as much help as you've been. We'll work together to try to actually get the patient guides too, and try to find out a way to get it. And then we're going to be meeting with the champions and try to how to practically do this. Kind of going forward for everybody who's not necessarily a champion, that we're still working on this in the background and trying to get our feet off the ground. The only question I have is, Leah, are you able to send us the Zoom link for those who were not able to make the meeting?
Absolutely. So I was going to chime in with some next steps. And that includes, you'll get a follow-up email from us, from me most likely, with a link to the Zoom. It's going to take a little while because this is a large file and it's got to download, so probably tomorrow. But you'll